Sir. Arush.
Yeah, thank you. So we will start off with the next session, that is Day School in Spine Imaging. It's a symposium, and I would like to invite the moderators for this session, Dr. P. Upendra, Dr. Kalidatta Das, and Dr. Kenny David. Uh, Amongst the presenters, we are still waiting for Dr. Harsh Mahajan to join. So maybe I request the moderators to start off with the second talk, please. And we will have Dr. Mahajan as soon as he joins. Over to you, the moderators. Thank you.
Surely. Thanks. Thank you. I think we are going to have an interesting session on spinal imaging. So without wasting much time, I would request Dr. Rishi Khanna to present his lecture on MRI on spinal infections in disease and with healing.
Good afternoon, friends. So this presentation is about the role of magnetic resonance imaging in spinal infections. So the diagnosis of spinal infections is based on the multiple factors. So we take into consideration the clinical presentation of the patient, the radiological features, and the laboratory findings. But even then, MRI has revolutionized the diagnosis of spinal infections. The gold standard imaging modality, as we see in this patient who presented with the almost normal looking radiograph, but had extensive abscess within the spine and the pelvic regions. So in terms of spinal infections, MRI has a high specificity and sensitivity, almost greater than 95%. So a classical spinal infection, which goes by different terms like discitis, spondylitis, or vertebral osteomyelitis, involves the infection of two adjacent vertebrae with an intervening disc and an abscess formation either within the vertebra or in the surrounding region. So basic thing in an MRI is the diagnosis of infection is based on the presence of fluid signals, either because of edema or abscess within the vertebra or the disc or the vertebral end plate, which is seen as classically T1 hypointensity and T2 hyperintensity. So presence of these two signal changes is the key factor which the radiologist use to make a diagnosis of a spinal infection. So this is the classical early MRI finding which we see in a patient with spondylodiscitis. So hypointensity in T1 sagittal image, hyperintensity within the vertebra and the disc in T2 sagittal images. And in the T2 axial images, we look for paravertebral abscess collections. So the edema and the abscess are the key diagnostic features to make a diagnosis of spinal infections. Sometimes in doubtful situations or to accentuate the findings which we see in a conventional MRI image, we use special sequences like a T2 fat suppressed, also called as the stir images. And we also use sometimes post-contrast T1 images. So in advanced stage, you see more extensive changes like end plate erosions, vertebral destructions, collapse, kyphosis, and extensive abscess formation, wherein the diagnosis is pretty much straightforward for us. So what are all the specific situations where we use an MRI to enhance our understanding of spinal infection? One is to diagnose a patient who has an early suspected spinal infection. Second is to differentiate a pyogenic infection with a tubercular with a certain degree of certainty, and differentiate modic changes from early spinal infections, malignancy from spinal infection, and an osteoporotic collapse from a spinal infection. Sometimes to diagnose an early postoperative infection also, MRI is very helpful. So coming to early infection, so this is a classical example, a 70-year-old gentleman who presented with increasing onset of upper back pain for the last 2 months. And when we took an X-ray, the X-ray was not very classical except for a suspicious spondylotic or spondylitic changes within the thoracic vertebra. When we did an MRI, it showed the classical presence of hyperintensity within the vertebral body and the disc of a spinal infection. And in addition, we also were surprised to see a mycotic aneurysm within the aorta, which probably was the initiating source of the spinal infection. So how are we going to use MRI to differentiate a tuberculosis from a pyogenic infection? So a classical description of a pyogenic infection is it affects the lumbar vertebra, And in a pyogenic infection, because the pyogenic organisms release a lot of proteolytic enzymes, the intervertebral disc is much earlier affected in comparison to a tubercular infection. So you see fluid signal changes within the disc along with the vertebral fluid collection early in the course of the disease in a pyogenic infection. And in a pyogenic infection, we also like to differentiate an abscess from a phlegmon. A phlegmon is also another name for a granulation tissue. So an abscess is one where you see a circumscribed uniform fluid signal, which is seen as bright in T2. And if you give a contrast, there will be a peripheral enhancement. An abscess responds very well to drainage or an antibiotic therapy. Whereas a phlegmon, which is a granulation tissue, this is classically seen as ill-defined, variegated appearance within the vertebral collection. So when we give a contrast, it shows a full enhancement. So a granulation tissue or a phlegmon indicates a poor prognosis in a patient with a spinal infection. So tuberculosis MRI is almost as equivalent to a chest X-ray in a patient with a pulmonary tuberculosis. So there are different pathognomonic findings in the MRI, which helps us to make a diagnosis of spinal tuberculosis with a certain degree of confirmation. So a well-defined paraspinal collection, thin smooth abscess wall where the wall diameter is less than 2 millimeter. Subligamentous spread of the abscess to 3 or more vertebral levels. Multiple adjacent vertebral involvement, and where an entire vertebral body is completely affected associated with the vertebral collapse. Presence of multiple skip lesions and large paraspinal abscess. All these things are very classical of spinal tuberculosis. So as earlier described, so this is a patient with a spinal tuberculosis. So we can see the entire gamut of pathognomonic findings which we described earlier in this particular patient. So to differentiate tuberculosis from pyogenic spondylodiscitis, so first we go by the history. So you have a chronic duration of symptoms, and there is an insidious onset. Thoracic vertebra is more affected in tuberculosis, whereas lumbar is more affected in pyogenic. And anterior part of the vertebra is typically affected because there is a subligamentous spread, whereas in a pyogenic infection, the infection tries to spread circumferentially around the vertebra. So you get an epidural abscess early in the course of the disease in pyogenic infection. So as discussed earlier, disc is preserved well in the course of the disease in tuberculosis, whereas early in the disease itself, you have a disc involvement in pyogenic infection. Tuberculosis is characterized by vertical spread of infection, whereas in pyogenic infection, it is circumferential or transverse. This is an example of a patient with a tuberculous spondylodiscitis. You can see a huge psoas abscess, but the disc is preserved as shown by the yellow arrow. So how to differentiate an early infection from a type 1 modic change? So a type 1 modic change is described to have hypointensity in T1 and hyperintensity in T2 images, which brights up in stir sequences. So the key finding is the color of the intervertebral disc. So as we can see in the comparison pictures here, so in a modic type 1 change, the disc is completely black, similar to a degenerated Fuhrman's grade 5 disc. You don't see any paravertebral collection with around the afflicted vertebrae. Whereas in a pyogenic infection, you see that the disc is bright. So this is presence of the fluid within the disc space, and you can see a perivertebral granulation tissue around the abscess. So this is in favor of a pyogenic infection. Similarly, an aggressive Schmall's node where the disc migrates within the vertebral body can also elicit a strong vertebral reaction and edema. So that could be confusing in some situations. But again, you look for the color of the disc. So the disc is degenerated and black, it's more in favor of Schmall's. Whereas if it is affecting the disc with a fluid signal, it is more in favor of discitis. And also look at the paraspinal collection in these patients. Compression fractures can sometimes be confusing, especially in the acute stage. So acute stage, it is characterized by T1 hypointensity. But again, look at the disc and look for any paraspinal collection. So the disc appears normal and there is no collection either with around the vertebra, in front, back, and in the sides. There are no collection, then it is more in favor of a compression. This is a classical example, 80-year-old patient who presented with severe back pain following a trauma sustained a month ago. So there was a suspicion of a compression fracture, but when we did an MRI, it had the classical features of T1 hypointensity, variegated T2 hyperintensity, and paravertebral abscess of spinal infection. So CT was also performed to confirm the irregular destruction. Metastasis can be sometimes confusing. So the key feature is you have hypointensity in both T1 as well as T2 images, whereas in a spinal infection, you will have T2 hyperintensity. And there will be extensive vertebral involvement, especially the ilium will also be affected in a patient with metastasis. So always look at the coronal images. And typically in the coronal images, you don't see any paravertebral collection, which you see in a spinal infection. Early in the course of the disease itself, you see the posterior elements getting affected. That's why you have the typical winking out sign in a patient with a metastasis. Speaking about the healing after a spinal infection, MRI is very helpful. So it has two roles. One is to assess the efficacy of an antibiotic therapy which you have started. So this is a patient for whom an antibiotic has been started. So L45 spondylolisthesis with a huge epidural abscess. You see at the end of 6 weeks, there is a very good resolution of the abscess. So to assess the healing of the disease during the course of a treatment, what we call as an interval MRI is very helpful. But in the later stages after the completion of treatment, especially in patients with spinal tuberculosis, where we are not sure when to stop the antitubercular treatment, 9 months or 12 months, these changes, resolution of soft tissue change, resolution of abscess, deposition of fat in the bone marrow, and bone effusion are very well shown in spinal tuberculosis. The follow-up MRI. So classical example. So a patient with spinal tuberculosis, you can see there is abscess around the vertebra. So abscess within the vertebra, T1 hypo, T2 hyper, stirred hyper. Whereas in the follow-up MRI at the end of 9 months, all the abscess has resolved. And you can see the abscess within the vertebra is resolved. There is fatty deposition within the vertebra, and both the bones have completely fused together. So in summary, MRI is a very essential and an useful thing to analyze the patient with a spinal infection. So early stages, everything is based on the fluid signal change, T1 hypo and T2 hyperintensity. And it is also useful to differentiate an abscess from a granulation tissue. Tuberculosis has some classical diagnostic MRI features, and we can also use it to differentiate infection from other pathologies as well as degenerative changes. And again, it is useful to assess healing as well as an interval MRI as well as a completion MRI. Thank you.
Thank you, Rishi. Dr. Kalidatya Das, can you invite Dr. Harsh? I think Dr. Harsh is there.
Yeah, we'd like to invite, we'll have the pleasure of having Dr. Harsh Mahajan to speak on his experiences of the vast 25 years of experience on MRI, and it would be a pleasure listening to him. Dr. Harsh Mahajan, please.
Thank you so very much for this honor. And I take you straight to my slides. And I'll be talking on normal and abnormal MRI following lumbar disc surgery. And really, if we talk about normal post-discectomy MRI findings can be divided into early and late, 6 months and after 6 months, and changes occur in all the elements. Normal findings early post-op on T2 weighted images, high signal band extending from the nucleus pulposus to the site of annular disruption, post-contrast enhancement of the disc and annulus, and this is normal. And epidural soft tissue signal due to epidural edema along the operative tract with or without mass effect, and ultimately replaced by epidural fibrosis as a part of the normal reparative process. And there is also nerve root enhancement, which is due to breakdown of blood-nerve barrier, normal at 6 weeks, reduces at 3 months, and usually you'll find no enhancement at 6 months. Early post-op, if we look at the vertebral end plates, edema may still be seen as stir hyperintensity. In the laminectomy, space apart from absence of the lamina, space may be filled by intermediate signal. In the paraspinal muscles, there's disruption and edema and later mature scar, and you may have small serous fluid collections in the soft tissues. Now, it's very important to do a dedicated MR when there's metal hardware, and that makes it tough for imaging. A lower field strength, 1.5 Tesla, is better than 3. There is special metal suppression sequences, Maverick, that we use. And there are various other ways that we try to reduce the artifact. Low field MRI, especially weight bearing, since it's physiological, reduces artifact and also gives you the physiological change, instability, if it exists, on weight bearing MRI. And we'll see some of that. And there is also on CT, there are artifacts, and a dual energy spectral CT is the ultimate tool for metal suppression. These are T2 weighted images that you can see with with the metal suppression, and you can see that there's hardly any artifact from the metal here. And this is dual energy spectral CT. Again, the beam hardening artifact, which is a hallmark of CT, is taken up by this. And these are CTs which are very expensive, and there are a handful of these in the country. And this is from our own case. This is normal post discectomy T2 weighted axial and sagittal images. There's the defect. And here you see this little bulge and the T2 hyperintensity. This is not a residual disc. And this is something which we keep hammering to our radiology colleagues. Do not call this, because there are medical legal problems that may be associated. This is normal post-operative. And after giving contrast, you can have enhancement of the disc here. As you can see on the axial images here, this too is normal. This is in the presence of metal hardware, and once you've used the right sequences, you get very little artifact. Also, it's also dependent on metal composition of the screws that are used. Again, on the axial, you can see very nicely here. This is post-operative T2 showing herniation of the dural sac through the segment of laminectomy. Again, this is a normal finding and not a problem. Plain and contrast enhanced T1 weighted images where you can see early post-op and 3 years later. This is early post-op, the signal abnormality in the epidural fat plane and showing enhancement here. And the same case was asymptomatic, and you see that this has nearly disappeared. So you may have early normal post-op enhancement. The findings post-discectomy, which are abnormal, we know the list is long: recurrent disc herniation, epidural fibrosis, hematoma, pseudomeningocele, and so on and so forth. Now, recurrent disc herniation, the one thing we need to remember that the herniated disc tissue has the same signal, or should have the same signal, as the parent disc. And after contrast administration, the disc material is not immediately enhanced. There is peripheral enhancement because of granulation or dilated tissue of the epidural plexus, and this is at the advancing edge of the disc. This is a case where you see recurrent disc herniation, large extruded disc material, and you can see only the advancing edge of the disc is enhancing. The disc material itself shows no enhancement. The same seen on these axial images. And here again, the advancing edge of the disc is enhancing. This is a case of a recurrent disc with arachnoiditis. And for the radiologist, it's very necessary to recognize this rope-like appearance where the nerve roots are fused together. And the problem post-op was not due to this recurrent disc, but due to arachnoiditis. And it's important in every case to mention it if we find it. Epidural fibrosis, most patients are asymptomatic. And it has been seen that extensive epidural fibrosis patients are 3.2 times more likely to experience recurrent radicular pain. And we use contrast here to make the differentiation, and the accuracy of contrast enhanced MRI is as high as 96%. Contrast is particularly useful when a mixture of scar and recurrent disc herniation is found. And there are various ways that radiologists determine the difference between the two. And this is one such case where you see this is a 36-year-old female, backache, left lower limb pain, and here you can see the recurrent disc, and it's a small one, possibly not really of much consequence, and the epidural scar is actually showing the enhancement. On the plain scan, it's very difficult to make the differentiation. Again, another case, 38-year-old, where you see this signal alteration in the anterior epidural space on this T2 and T1 weighted images. Note that this is not really causing any compression of the thecal sac. If anything, the thecal sac is being pulled towards the fibrosis. And this is, we do MR neurography in cases, and this is where there was the entrapment of the nerve root, and you see this signal alteration distal to it, which is due to restricted diffusion. So this is the site of entrapment, and this is the restricted diffusion. So in a given case where you don't get an answer, even with contrast, an MR neurography can be very useful. Another 58-year-old with backache, and here you see that there is hardly anything that you can say on these plain axial images. Of course, there's some signal alteration in the epidural fat here. After giving contrast, you see that this is epidural fibrosis, seeing this inhomogeneous contrast enhancement. Pseudomeningocele, this is a pseudocyst. There is no true meningeal lining, and localized collection of fluid communicates with the thecal sac. It affects only a minority of patients, but when it does, it can be a problem. As you can see here, a large pseudomeningocele communicating with the thecal sac here. The same you can see on the axial images here, where there's also metal hardware. Epidural hematomas may occur rarely, and this is one such case, and the hemorrhage has typical signal characteristics which we can identify on MRI, and this is markedly compressing the thecal sac and the nerve roots. Post-operative infection, we've heard about tuberculosis just now. This originates as discitis and less commonly as facet joint infection, and it may extend into the adjacent structures after that. Diffusion-weighted MRI, as in an abscess anywhere in the body, can be useful because these show restricted diffusion. On contrast, the most reliable pattern is enhancement of the disc, the annulus, as well as the vertebral body itself, the marrow. This is a case here where you see this is a 64-year-old operated TLIF, and here you see this large fluid collection, the same seen here. And in this, you see that the collection has gone down after 3 months. This is another case, 36-year-old post-op pain. And here what you see is a collection here. And this is in the surgical tract that you're able to see extension of fluid due to infection. And this is another case where you see T2 hyperintensity better seen on these STIR images. And this is also hypointensity within the vertebral bodies, the end plates, as well as note the signal intensity, bright signal within the intervertebral disc, and this collection posteriorly and enhancement of the vertebral body, the disc, as well as the granulation tissue. And this is a classical case of post-operative infection. It's important, as has been said earlier in infection, that the signal of the disc has to be bright. Another case, post-op infection, where you see this large fluid level, a large, and there's enhancement of the vertebral disc. Also see this enhancement here. Arachnoiditis, we've talked about this, and there are 3 patterns that are recognized. This is what is called the empty sac, where the thickened nerve roots are plastered to the thecal sac itself. There can also be adjacent level failure, which you need to recognize and which may be responsible for the symptoms. Your surgery was perfect, and this is one such case, a disc herniation at a higher level with a thickened ligamentum flavum causing all the compression and the symptoms. Weight-bearing MRI, and you can do it in the supine or the erect position at any degree of making it erect. And upright MRI allows the entire spine to be imaged in its physiological weight-bearing stage. An assessment of occult disease not visualized on conventional supine imaging is possible. This is a normal case where, you see that there is increase in lordosis on weight-bearing. This is normally seen. We know this from X-rays. Now, this is a case, supine T2 weighted image, large disc at L5-S1 level, T1 weighted image, large disc. But when you put the patient upright, and this patient was having symptoms on sitting and standing, we see that the disc has got squished and the entire material goes posteriorly and is causing marked compression of the thecal sac. So this is how weight-bearing MRI can be useful, that it shows you that there is clinically significant problem that's happening. That's another case of spondylolisthesis, grade 1 becoming grade 2 on making it upright, and also the compression on the nerve roots. All of those can be seen very, very well. And this is in the presence of hardware. Since it's a low field MRI, you hardly get any artifacts, plus you have the advantage of weight bearing. In conclusion, I'd like to say imaging approach to post-operative spinal MRI has to be very different from a routine MRI. A radiologist's personal oversight at the time of imaging can make the difference between a correct diagnosis and missing a diagnosis or a misdiagnosis. 1.5 Tesla to be preferred over 3 Tesla. A weight-bearing MRI may unfold hidden abnormalities. A contrast-enhanced MRI is very useful. An MR neurography may be useful if routine MRI is inconclusive and requires high-end MRI and a dedicated radiologist. And to conclude, the person behind the machine, the radiologist sitting behind the machine, may be more important than the machine itself. Thank you so very much for your attention.
Thank you, sir. Thank you so much for the enlightening talk. We will have all the questions at the end of the session. So the next talk would be by Dr. Ravi Thapar on post-operative fluid collections. So I would be inviting Dr. Ravi Thapar to give his talk.
Good evening, I am Dr. Gautam Zaveri.
And I am Dr. Ravi Thapar, and today we will be discussing about the post-operative fluid collections in spine.
The number of spine surgeries has increased dramatically over the past few decades. Following spine surgery, occasionally patients may present to you with a swelling or increasing pain in the back. In this case, one needs to ascertain whether the fluid collection is a seroma, a hematoma, or something else. Sometimes the patient may present for some other problem and a diagnostic imaging may show fluid collection. It then becomes extremely difficult but vital to try and precisely diagnose what the fluid collection is.
So the 4 most common fluid collections that we routinely encounter are the seroma, hematoma, pseudomeningocele, and abscess. Now there is a lot of overlap between these fluid collections, and usually it is not possible to reach a single diagnosis by using a single modality. So generally it requires a combination of the clinical presentation, the blood picture, the imaging, along with the biochem and microbiology to reach the correct single diagnosis.
The first of these collections is a seroma. It is a collection of sterile, clear fluid that occurs anywhere along the path of surgery or often where the tissue has been removed. It basically consists of lymph or plasma that is seeped out of ruptured lymphatics or blood vessels and inflammatory fluid which is exudated when there are injured or dying cells. This is often admixed with blood. It usually forms 1 or 2 weeks after the surgery. surgery. The diagnosis of a seroma is often difficult, and it is usually by excluding other pathologies. Small seromas are usually asymptomatic. Large seromas may present with swelling superficially, they may present occasionally with pain, or they may leak through the incision site. Generally, there are no signs of inflammation or infection locally. There may be some tenderness or swelling. The blood picture is essentially non-contributory.
So on MRI, the seroma has a very innocuous appearance, just like its clinical picture. So on the T1 weighted images, it appears hypo-intense. It appears hyper-intense on the T2 weighted images. And on post-contrast imaging, it shows very thin peripheral uniform post-contrast enhancement. There may be minimal heterogeneity within the seroma, but typically there will be no associated osseous findings.
If the diagnosis is still in doubt, or if the seroma is very large, causing discomfort to the patient, one may choose to aspirate it. One finds clear straw-colored fluid, which may be mixed with blood. The blood settles at the bottom of the tube. The fluid is not sticky, it has no flakes, it is sterile, there are no pus cells on biochemistry, and in biochemistry it is similar to plasma or lymph. The second swelling is a hematoma. It is basically a collection of blood outside of the blood vessels due to injury to the vessel wall. It may present within hours if there is acute hemorrhage, or up to days following a surgery. The hematomas can be located paraspinally, they may be in the epidural space or the subdural space. Smaller hematomas are usually asymptomatic and obviously very common after surgery. The problem is with the larger hematomas, which may present with swelling, or they may leak through the incision site, causing cross-contamination and infection. Acute hemorrhage may result in life-threatening complications because of blood loss, or acute hemorrhage may result in a collection of blood which causes pressure symptoms on the adjacent structures, resulting in respiratory distress in the cervical spine, or neurologic deficits when the hematoma is in the epidural space. Chronic hematomas appear insidiously, and as they grow, patient complains of more and more back pain. There may be radicular leg pain. Often this pain is shifting, and it is affected by posture. There may be subtle focal neurological deficits. On examination, there may be tenderness over the surgical site or in the paraspinal region. There may be local warmth. However, usually signs of inflammation and infection at surgical site are not there. The patient, however, is uncomfortable with movements and generally not a happy patient. There is, of course, a risk of secondary infection. Total count and hemoglobin are normal. ESR and CRP may be slightly elevated.
Now on radiographs, a hematoma may present with an increased prevertebral shadow like this, or on CT, it will typically show a hyperdense appearance. So that is a very important finding which will suggest the diagnosis of a hematoma, hyperdense appearance on the CT. As far as MR is concerned, the hematoma will be relatively hyper-intense on the T1 weighted images and relatively hypo-intense on the T2 weighted images with respect to the CSF. Now, the appearance of the hematoma keeps changing with time depending upon the degradation of the hemoglobin and also depending upon the liquefaction. But this kind of appearance, hypo on the T2 and hyper on T1, is typical for a hematoma. It may show internal heterogeneity with fluid levels, and if you do a gradient echo sequence, the hematoma will appear very dark.
Hematomas must not be aspirated as far as possible for fear of introducing infection. However, if it's a large hematoma and patient is uncomfortable, one may aspirate it using a thick needle because it is difficult to aspirate clots, and therefore it usually requires a surgical evacuation. The next swelling we talk about is a pseudomeningocele, an extradural collection of CSF that extravasates from an intraoperative dural tear. It can vary in time to presentation. Some pseudomeningoceles, especially from a large puncture, can present almost immediately post-surgery within a matter of days, and some may present over a matter of weeks to months if it's a very small breach. The diagnosis of a pseudomeningocele again rests upon a clinical picture and the imaging. A smaller pseudomeningoceles are asymptomatic. Larger pseudomeningoceles may appear as swellings. There may be leakage to the surgical site or the drain site causing a CSF fistula. Patients are usually asymptomatic, but a very large swelling can cause pressure symptoms resulting in back pain, radicular leg pain, or symptoms because of coning, which include headache, dizziness, nausea, vomiting, blurry vision, diplopia, and photophobia. The blood picture is essentially normal.
So on MR, pseudomeningocele will show the typical findings that are expected of it. It is a collection of CSF, so it will exactly follow the CSF signal on all the pulse sequences. It will be markedly bright on T2 and dark on T1. So much so that if you do a myelography sequence where we only get the CSF images, the pseudomeningocele will be seen in that image as well. If we give contrast, it will show very thin peripheral uniform enhancement.
Aspirating a pseudomeningocele is required when the patient is extremely uncomfortable because of the size of it, and usually it reveals clear watery fluid. Occasionally it may be admixed with blood in the post-operative setting. When you put the fluid on a filter paper, it reveals a double ring sign. The blood tends to concentrate in the center where the CSF migrates to the periphery, forming a double ring. CSF also has a very peculiar chemical inside it called as the beta-2 transferrin, which can be found on examination in the biochemistry lab. The last swelling we discussed is an abscess, which is a collection of pus secondary to a surgical site infection. It may be superficial, paraspinal, epidural, and very rarely intradural. It usually appears between 5 days to a month after the surgery. Misdiagnosis and delays in diagnosis are extremely common. The patient typically has increasing back pain which is unexplained. Pain may start eventually radiating to the leg. There may be a progressive neurologic deficit. The constitutional symptoms may be present, signs may be present such as increased temperature, but look for subtle signs such as tachycardia and tachypnea. Local examination may reveal swelling, local warmth, erythema, shininess or tenderness at the wound. Movements will be painful and restricted. The bloods show an increased leukocytosis, WBC count with leukocytosis, and raised ESR and CRP.
Now, like everywhere in the body, the abscess has a very typical MR appearance. It is dark on T1 and it is bright on T2, but because it is a turbid fluid collection, it will not be as dark as the CSF on T1 and not as bright as CSF on T2. More importantly, the main hallmark of an abscess is the post-contrast enhancement. It shows a very thick, irregular peripheral rind of enhancement, and this makes it the most likely diagnosis. Also, along with that, if you find ancillary osseous features, like if you see there is evidence of infection in the marrow as well here, which is dark on T1 and which is showing exaggerated post-contrast enhancement, that makes the diagnosis of abscess all the more likely.
Once the diagnosis of an abscess is made, one generally goes for a wound wash or an irrigation, and rarely does one need to aspirate it. But if one does, one uses a wide bore needle and one finds yellowish, thick, flaky fluid, which is sticky if you take it on the hand. So to conclude, the precise diagnosis of a postoperative fluid collection is extremely vital to plan appropriate treatment, but it can be extremely challenging. And it requires a combination of your clinical skills, blood tests, and imaging in order to be able to reach a perfect diagnosis. In spite of that, if there is a doubt, then one might need to aspirate the fluid in order to reach a diagnosis. Remember that seromas and pseudomeningoceles are primarily painless. The hematomas and abscesses are not only painful, but they can result in a progressive deficit. Blood tests are usually non-specific and of limited use except in patients with abscesses. MRI is the most sensitive and specific test to help us differentiate between these collections. However, when you do an MRI, you must order all the sequences so that you can get the best information. Rarely one does require an aspiration.
So while concluding, I would just like to highlight the hallmarks of the 4 fluid collections that we tackled. A seroma, hypointense on T1, hyperintense on T2 with very nice thin peripheral enhancement. Hematoma, it is the one which is relatively darker on the T2 weighted images and brighter on the T1 weighted images. CSF leak, We'll follow the CSF signal on all the pulse sequences, very bright on T2 weighted images, and will also be seen on the myelogram. And abscess, the hallmark of which is a thick peripheral rind of enhancement and initially findings in the bones as well, indicating infection.
Thank you very much.
Thank you, Dr. Gautam, and thank you, Ravi, for a very elaborate discussion on the postoperative fluid collections. Do we have Dr. Kenny David, sir? Yeah, you can unmute, sir.
Yeah, hi.
So
Hi.
yeah, hi. So
Gentlemen, good afternoon. Yeah. We're going to have Dr. Naresh speaking to us on assessment of spinal fusion, a very important clinical scenario, and all of us need to hear that. So, Dr. Naresh, please go ahead with your talk on spinal fusion assessment.
Good afternoon. My topic for the day is on spinal fusion assessment. So we all know that spinal fusion is an important integral part of routine spine surgeries. With the advent of pedicle screws and powerful instrumentations and osteobiologics, the fusion rates have tremendously improved, but still there are chances of spinal fusion failures, which is a serious concern. This can be up to 23.6% revisions, which are due to failure of the fusions. So this figure may underestimate the true incidence of non-union because of the pseudoarthrosis can be asymptomatic as well. The mainstay of radiological assessment of fusion is by plain radiographs, either static or dynamic CT scan, and now the MRI, ultrasound, and PET-CT are also being used to assess this form. The radiographic assessment by static radiographs are the primary because they are readily available, but they tend to overestimate the non-unions, failure of the fusion, because the incorporation of the graft cannot be seen early in the disease. Dynamic radiographs, they improve the accuracy of radiographs, but the reliability is a question. Inter-observed reliability is a big problem, and the allowable motion to label a fusion to be a non-union or a pseudoarthrosis is there is a controversy still exists, but these are the only 2D assessments of the fusion. One need to remember that lack of movement at a fused segment does not confirm the fusion. The static radiographs, they take a long time to detect the fusion, which can be up to 3.5 years. The correlation of the static radiographs with the surgical exploration is found up to be 64% of sensitivity. It means that if an X-ray demonstrates a solid fusion, it is likely to be solid. But if it suggests pseudoarthrosis, then it cannot be relied upon because this needs to be further confirmed with the dynamic radiographs. The correlation of lumbar flexion extension radiography with the surgical exploration has been done by Brodesky with 62% of correlation. The controversy still exists on the amount of the motion to label a patient as a failure of the fusion. It can range from 0 to 5 degrees, and the presence of rigid instrumentation sometimes makes it a problem, because the presence of the broken screws always imply that there is a failure of the fusion. The measurement criteria different criteria were available. The most commonly used measurement criteria is by Simons, where he quotes more than 2 degrees of angulation change in the flexion extension is labeled as a non-union. Hutter's method is popularly used by the radiologist, where they try to superimpose the flexion X-ray with the extension X-ray and identify the failure of the fusion. In cases where there is a plate applied onto the interbody plate in the anterior plating, the spinous process movement or interspinous motion can be used as a reliable indicator for the failure of the fusion. CT scans are the mainstay in identifying the fusion, but early studies have quoted only 57% correlation with the surgical exploration. But the recent studies have documented up to 80% because of the advent of fine cut imaging, multiplanar reconstructions, and metal artifact reduction. But one needs to be cautious about the high radiation exposure with CT scans. The signs of fusion are very important to know. These are the most important sign is a bridging bony trabecular bone, which is popularly known as BTB. So if you see BTB is a continuous bone density with remodeling. So it starts in phases. Initially, the bone density decreases and it becomes isodense with adjacent medullary bone, and then trabecular bone develops, vertebral interprets, subchondral bone dissolves, and the demarcation between the fusion mass and the adjacent medullary bone gets lost. The bridging trabecular bone can be discontinuous in the cases of non-union or delayed union, or you can see defects inside bridging bone trabeculae, and sometimes there is a lucencies and there is a discontinuity there also. The second important radiological sign is continuous bone density. Continuous bone density is not diagnostic of solid fusion, but one needs to remember when in cases where there is a cage put in, the packed divascular bone grafts are also can also be seen as a continuous bone density areas. So the continuous bone density within the interbody cage is not reliable, but if it is seen outside the cage, it's very significant. So they are all similar to the anterior and posterior sentinel signs, which has 61 to 74% accuracy when they are present. The marginal radiolucencies, they indicate the failure of the fusion, a failure of the implant to incorporate in the interbody. At least 50% of the surface should be involved to label it as a failure of fusion. So it's very important to know which are the implant, the material used in the implant is very important to know, because titanium and the peak cages are the commonly used peak cages. Whenever we use a titanium implant, the titanium is osteointegrative, in the sense the surface oxide acts as a platform for the hydroxyapatite to form a bony layer. So the radiolucencies seen with the titanium implants, they indicate a problem. So there is a non-union developing when you notice a radiolucency around the titanium implant. But that's not true with the peak implant, because peaks are not osteointegrative. There is a thin fibrous film which forms around the peak cage, and the fusion develops around this thin layer. So it's a normal finding with the peak cage, unless it's a too much extensively seen radiolucency. So these radiolucencies sometimes are associated with other gas formations and cystic formations, which are also indicative of failure of fusion. Coming to the specific types of the fusions, posterolateral fusion is the one which is initially thoroughly assessed with CT scans. This can happen with the facets and the posterolateral gutters. When we see both the facets and posterolateral gutters are fused, there is a 96% chance of fusion. But if only posterolateral gutters are fused, it falls down to 89%. And if you see only facets fused, so it is a 74% chance of fusion in the surgical explorations. However, the absence of fusion across the both facet joints and one posterolateral gutter did not reliably predict the pseudoarthrosis and exploration. Basing on these criteria, Higgins and S actually classified the posterolateral fusions or non-unions or pseudoarthrosis in the posterolateral fusions into atrophic, transverse, shingle, and complex type of fusions. And Lenke has simplified this into 4 categories, where there is a definitely solid, where you see big trabecular bone bilaterally, fusion mass bilaterally, probably solid when there is a unilateral large fusion mass with contralateral small fusion mass, and small thin fusion mass on both sides will be probably not solid. If the grafts are resolved bilaterally, the fusion mass is obviously there is a bilateral pseudoarthrosis. This is an important, useful classification in the basing on the CT scans in the posterolateral fusions. Coming to the interbody fusions, so it is very difficult to assess the fusion in the interbody because of the artifacts. But now we have protocols where we can identify these things. So there's one famous classification is the BSF classification, where they try to assess the interbody fusion developed by Bennington, Steffi, and Fraser. BSF 1 is where there are areas of gross signs of movement, which indicates a failure of fusion. BSF 2 is a kind of locked pseudoarthrosis, where there is a lucency horizontally, but there is a fusion mass around the horizontal lucency. And BSF 3 is quoted as fused intervertebral body fusion. Coming to BSF 1 can be of different forms. It can be collapse of construct, loss of disc height, vertebral slips and broken screws, displacement of cage, and lucency is seen around the periphery of the graft and pedicle screws. They indicate failure of the fusion. BSF2 is the one which we are talking about. There is a lucency inside the cage and there is a bone fusion around that area. These are popularly known as locked pseudoarthrosis. There is also timeline for fusion. The CT scans taken at early in 6 months can show some amount of fusion, but at the 10 months you can see the small fusion happening in the surrounding bone also. Sometimes they tend to subside inside the vertebral body and fuse, and there is a sentinel bone formation seen in the anterior, posterior, and even in the lateral sides. But if you notice the lucencies around the cage, they always indicate a kind of failure, especially in the titanium implants. Kanemura has actually described the sequence of events what can happen with these fusions. The motion of greater than 5 degrees and dynamic X-rays can be noticed till 1 year, but they steadily resolve over a period of time. So one need to be patient to wait. And it's not alarming once you see a failure of fusion of more than 5 degrees in a dynamic X-ray. Radiolucent zones around the pedicle screw also resolve over 3 to 4 years. And the anterior bridging of bone began to see at 3 months, and the interbody fusion graft volume, they tend to decrease by 6 months. Actually, the volume of graft decreases by 6 months and then slowly increases. So the delay in surgical intervention probably can be taken a decision based on the clinical findings with the patient. So MRI is also been used nowadays to study the fusion. But the metallic susceptibility with metallic artifacts are the one which are the limitations. But you can see the CT scan and compare it to MRI, which shows similar findings, especially in the interbody area. This can be used in the patients with the post-instrumentations. Ultrasonography and nuclear medicine have been tried, but with very low sensitivity. To summarize, the dynamic radiographs and CT scan are the mainstay in assessing the fusion, but CT remains the choice of investigation in doubtful cases. And the CT changes are dynamic. The lucencies in the early course of the disease tend to progress into solid fusion with the time. No single investigation is diagnostic, but they are complementary to each other. Thank you very much for your kind attention.
Thank you, Dr. Naresh. That was a very good, very informative talk. I think the time is now open for questions. Can I just kick off by asking Dr. Rishi? Dr. Rishi, that was great work. In fact, all papers have been very informative, very full of clinical knowledge and pearls. Dr. Rishi, I had a small question for you. You started off by showing us the combination of clinical, radiological, and lab to make a diagnosis of infection. And I think MRIs are very important in that. But do you find the MRI as useful when you want to stop infection, stop the treatment? My suspicion is that an MRI, especially in tuberculosis, is less helpful to decide the end point of treatment, rather, as compared to clinical and lab. When you compare it to initiating treatment, would you agree with that, or what's your perspective on that?
No, yes, that's perfectly true, sir. So for MRI is very useful for initiating treatment, but the end point of treatment, MRI is one of the corroborative tool to help us make a decision to stop antitubercular treatment. Of course, at the end of 9 months, we assess the patient clinically, and X-ray wise, if it is completely fused, then we don't usually do an MRI to stop antitubercular treatment. Because sometimes patients themselves take an MRI and come, even though there is complete fusion, no clinical symptoms, laboratory parameters have all returned to normalcy, but you see three areas of abscesses, what we call as a sterile abscess in and around the psoas region. So MRI, as you said, it's one of the tools to help us.
Thank you.
I'll go second. Rishi, there are, as the patient is improving, patient is still, nowadays patients have very easy access to the doctor, and therefore in 2 weeks, if they are not better, suddenly they are on your neck asking why I'm not better. So often what happens is 6 weeks down the line, patient has not gotten better. He approaches his spine surgeon repeats an MRI, and that actually looks worse than before. when you ask the patient clinically, they have had some weight gain, the fever has gone down a little bit, their pain is also better, but it's not completely gone. So if you, at this stage, if the abscess has increased, your vertebral body and destruction has slightly increased, how would you interpret the MRI?
So in the when you have a reduction in the clinical symptoms, and MRI shows, even though it may show an increase in the abscess, if it is not encroaching into the spinal canal and doesn't cause any fresh neurological compression, or if there is no instability of the bones, then I still try to reassure the patient that this is a normal observation which we see in the first 6 to 8 weeks of treatment. And MRI always lags behind the clinical improvement by at least 3 or 4 weeks. So don't rush in to have a surgery, because the medicines take some time to work, and the bone takes some time to heal. By the time you will feel better.
So what is the time period till which you would accept these pictures? Say suppose the same MRI 3 months down the line continues to show the same picture. Is that a worrisome sign at that point?
Yeah. So like I said, if there is no instability, and the clinically if the patient is improving and there is no cord compression, in the absence of any myelopathic signs, there is no need to rush in at least till 3 months.
Okay, 6 months down the line?
6 months down the line, if it is still not healing, I think it's better to relook at the diagnosis. So if either your biopsy, whatever we had done initially, may not be the proper one, maybe we have missed multi-drug resistant tuberculosis or a coexistent infection, or sometimes lymphoma. We have burnt our fingers a few times where the patient at the end of 6 or 7 months turned out to be a lymphoma when we did a rebiopsy again. So 6 months down the line, if there is no improvement in an MRI, I think it's better to rethink the whole process of evaluation.
And about 3 to 6 months, 4 months down the line, the patient is actually improving. The radiological picture MRI is also improving, and you find the lesion at L12, which was the original lesion, is improving. Now you have a fresh lesion at D1110. What then?
It happens sometimes even at the completion of 9 months. When we take an MRI, we see a new lesion cropping up somewhere adjacent to the previous site. So we continue with the same anti-tubercular treatment. There are a group of patients where you can't stop at the end of 9 months. For example, like you can say like 80% of the patients become completely all right by 9 months. But there are some group of patients who, despite not having a drug-resistant tuberculosis, may have a bacteria, probably a genetic reason or a deficient immunity, which makes them to require a continuous anti-tubercular treatment till 12 or 18 months.
Right. I may come back to you again. Upendra, if you don't mind, I am on a roll. Yeah.
I can see that, sir.
Dr. Mahajan, sometimes we find that in the post-operative period, after we've done a discectomy, etc., for whatever reason the MRI has been done, maybe the annulus is still looking as though there is a herniated disc over there. Now, the patient, obviously, it's reported by the radiologist, so annular bulge or a disc protrusion. And the patient comes asking, have you done a discectomy here or not? And that becomes a problem for us. How fast do annular deformations improve after surgery? And number two is, sometimes when we go in there, during surgery, it's a chronic disc, and what has happened is there is a combination of a very small osteophyte, which probably even on a CT scan may be difficult to really point out as a big osteophyte. But when we go in there, there is an osteophyte with a disc. We remove the disc, the patient's complaint gets resolved. But in the post-operative, if whatever reason the patient does an MRI and he complains of symptoms and we tell him there was an osteophyte, will the MRI show you that yes, this is a complete discectomy and that there was an osteophyte here which was the cause of complaint and there's nothing you can do about it? Dr. Mahajan, are you here? Yes, Ravi, the problem of annular bulges after the surgery, the annulus does take time for it to go back. It is often very thickened. How can you actually report that very clearly so that the patient does not get a feeling that something has gone wrong with
Yeah,
the
see,
surgery.
as Dr. Mahajan mentioned in his talk, I think up to 3 months you can expect some fullness at the site of the annular tear where the discectomy was done, and by 6 months you expect it to completely sort of regain its contour. So till 3 months, it is immediate post-op. It will be quite prominent. It will reduce by 3 months, and by 6 months you can expect the normal contour to be regained. So in the initial post-op scans, you will have to just mention it as a post-operative sequel.
Dr. Gautam, what we have found very important is if we have mentioned to the patient before surgery that there is around 3 to 5% chances of recurrent disc, then usually we can explain that.
Yeah.
Otherwise, it becomes very difficult post-operatively. They'll come back to you.
Dr. Naresh, I had this question about your assessment of fusion. Sometimes you can see a great posterolateral bone, posterolateral gutters with bone, but I'm never sure whether it is fused above and fused below, whether it is fused to the transverse process above and below. So you can have floating bone graft, which is a floating fusion mass, which is useless, in my opinion. As orthopedic surgeons, we know that a floating fusion mass is useless. It has to be anchored above and below. Have you ever had that problem where you have a lot of bone, but it is actually a non-union above and non-union below?
Exactly, sir. Yeah, I seen few cases like that when the patients actually they come for revision procedures. Whenever you're trying to decorticate the facets, you can see that the entire sheet of bone lifting up. And sometimes what is known as seen as a very stable one, after the removal of the osteophytes, they become very unstable. You are right in saying that just identifying the big block of bones on either side is not completely assures you that patient is not pseudoarthrotic, but that needs to be confirmed by flexion extension dynamic views and make sure that there is no movement at that particular time.
Can I ask?
Yeah, surely, sir.
Yeah, question to Naresh Babu. We do see patients who do not have interbody fusion. Neither they have posterolateral fusion. First few months, their pain has gone completely, and after that, patient starts pain. Patients come back to us and say that I have pain. And these cases, we always do the interbody fusion, but there are patients now who are operated by somebody, and there is no interbody fusion done. So and then we have been doing flexion extension X-ray, even CT scan. It doesn't show anything. And what normally we do, we inject the local anesthetic and then we operate them after that relief. We do the interbody fusion. Do you have any such protocol where how should we manage these cases?
So our protocol is we are little choosy on operating on cases where we can't find motion before surgery. For two reasons, I can't guarantee the success also after surgery, but I'll make sure that the reason for the pain. Most of the times, these are the ones where you identify some amount of loosening around the screws or some adjacent segment facet damage. Most of the times, they do respond. I also have cases where I can't find any reason for the pain, but when I operate them, thinking that there is some problem, and then after surgery they will recover. So might be thinking there is some amount of implant issues, which
micro movement happening.
Right,
okay, thank you.
I think Rishi has right.
Yeah, sir. So just an open question to Dr. Naresh and the other panelists. So we have done a fusion like 2 years ago, and the patient presents with back pain. So in the absence of any periscrew lucency or an implant failure, and without any radiculopathy, so if there is any pseudoarthrosis, so how many of us would try to go redo a fusion?
So patient comes back with pain, is it?
Only axial pain, no radiculopathy. We don't see an interbody fusion, but there is no implant lucency around the screws or no implant failure. So should we, how many would do a surgery?
I think Naresh just mentioned, Rishi, that he would be very, very choosy about such a patient, because these are patients where guarantee of success cannot be given, and therefore redoing a surgery is not. But if the patient eventually has very severe pain, then you have no option but to kind of complete the circle. I mean, one problem has happened, now you have to complete the circle, do the surgery. It may help or not help, but you should try to postpone it as much as possible.
Can I add to this? Normally what we do, Rishi, we the dye into the disc, and we give the disco block, the sensor cane, and then that is probably the pain generator. And we know that that's the pain generator. Patient will say that my pain is gone. Then we go in. So like Dr. Naresh Babu said, we certainly do not assure them, but we certainly do this sort of logical test.
Rishi, can I say something? I think, I think what I do is when I see L4-5 fusion and the patient comes back to me, surgery, and patient comes back to me without fusion, which I can see on the X-ray, but complaints of axial pain. And first thing, I probably look at the disc above and inject the facet and do a couple of facet blocks, understand the psychology of the patient before I actually touch him, and also look at the SI joints. I do a little bit of more investigation with this patient, get him 2-3 times to visit me, and look at his intensity of his problem and make some blocks and then check, and then only you wouldn't revise. Otherwise, you never touch them again.
Gentlemen, thank you very much. The session, please, in interest of the time. My apologies.
Surely. I think then should
Thank
we
you very much to the panelists in this session, Dr. Ravi Thapar, Dr. Rishi Khanna, Dr. Harsh Mahajan, and Dr. Naresh Babu for their excellent presentation. Very enlightening. I think one of the very best sessions in ASSI today, this time. I would also like to thank the moderators, Dr. Kenny David, Dr. Upendra, and Dr. Kalidatta Das for moderating it well and keeping it on time. It's time, as the conference comes to its last leg, to say some nice words, some kind words, and thank people. And who can do that better than our president, Dr. Chabra?
Thank you, Gautam. I think I'm very happy to say that we have created history. We have created history in that it is the first virtual Assicon. We had a conference last year, but that was only a pilot. So this was the first Assicon per se, virtual. And I hope all of you liked the conference. We have connected, we have discussed, we have learned, and we have also socialized, shared our knowledge. There have been all aspects of a conference, and I think we couldn't have expected anything better. There has been a large participation also. Gautam, if I'm right, there were 32 international faculty from 8 countries.
35,
right?
Yes, sir, 35.
And there were around 93 Indian faculty, a lot of participants. I think all good things need to come to an end, and so has to be this conference today. But you have a social program coming today at 6:30, and you will see your dynamic now secretary also sing with his daughter, and you will see other people. So do join for the social event. But I would only want to thank everyone. Want to thank all faculty, want to thank all participants, want to thank the whole executive, the organizing committee. I think the core executive, especially Ajoy, who could not participate in the conference but had put in a lot of effort, Gautam, Shankar, Somnajit, all of them have contributed largely to the conference. But I would also want to acknowledge the contribution of the whole executive. In fact, many of them have also, many of the executive members have also helped in coordinating the session. So all the coordinators of the sessions, you have done a great job. Thanks. All people who have contributed in any manner, and especially I would want to thank the Secretariat, and above all also you have seen Ankur being there in all of them, and all consultants of ISIC. So I can't take names of everyone. Thank you all. Have a great time. We'll see you today in the evening at 6:30. Have a great remaining part of the session, but look forward to enjoying together with you. Thank you, Gautam. And of course, you have the new president here with you, Dr. Shankaracharya. Shankar, would you want to say a few words?
Yes. Thank you, Chavra, for letting me speak a few words. I think this has been a fantastic conference. As you said, you have created history, and the credit goes to you, Gautam, Ajay, all the executive members, all the core committee members, all the foreign faculties, and the way that Gautam and you have planned and Ajay have planned is like we have three super generators. You've gone to a multi-storied building, and they first tell you, sir, इसमें 24-hour power supply है, कभी भी off नहीं होता. And I can sure all of you can vouch for Gautam Zaveri and Ajay Shetty and Chabra and his full team of Ankur and Neeraj and others always there. And I'm amazed at your energy, Gautam. So I'm glad that you are here. 24-hour power supply. न कभी भी बुझता नहीं है, but कभी कभी spark करता है. Or so that itself is fantastic. That I am so comforted by the thought that he will be always there. And the other thing is we must thank all the foreign faculty that they spend time day and night. I think there were odd hours of the time when they woke up and shared their time with us. And this is the first time in this first year with the corona pandemic, which I remember Chabra saying once that we must turn every adversity into an opportunity. And he has shown how visionary he is and how he has created all these adverse situations into opportunity. And thank you very much, Chabra and others who have all pitched in and got all these foreign faculties. For the first time, these foreign faculty names have become like Indian names. We see Sukensa, we see Kern Singh, we see Larry Lenke. When I went to US to hear Larry Lenke, and here we have Larry Lenke talking about his life, his style, and you have all these legends. Still 11 o'clock. Yesterday I normally sleep off at 11 o'clock, but this Gautam Javeri put it on till he passed 11. So it was so fascinating to hear all these people say that yesterday from 7:30 in the morning till 11:30 at night, I was glued. So I'm also going to get coccydynia because I don't have that muscle mass in my buttock that Gautam Javeri has for sure.
No, Gautam has lost all that, Shankar.
And I thank you all, and I thank your core ISIC team, and I thank you the AV. The audiovisual has been fantastic, and they have never let us down. I think at least not me. As soon as I said, put me on a panelist or I can't get communication, at least Neeraj, Ankur, Guru and Deepak from the AV always communicated with me. Thank you very much. I'm really honored to be taking this position, but I'm comforted with the fact that you're all there with me. Thank you.
Gautam, you will have to have the last word. Of course, I forgot to mention about Grovers, who did a wonderful job, Alpcord, and Neeraj's name, who contributed, Neeraj and Guru Raj, who contributed a lot. I missed also. Gautam?
Right. I think a lot has been said, and it's time to call an end to this conference and take you down to the last part of the program, and also invite you for this evening's program, 6:30 p.m. It is a local Spine ASSI orchestra, ASSI band, ASSI members and their families performing. I'm sure you're going to have a great time, and we have a very vibrant and energetic MC for the program, none other than our very own Dr. Bhai Nene. It's going to be great. Don't miss it. Get a couple of beers in your hand and join us for a grand party. And thank you all for joining, and we look forward to seeing you again in July, August when we hold the ICS. Let me thank the moderators of the session and the hall MCs, Dr. Tarun Rustagi, Dr. Neeraj, Dr. Ankur, and the rest of the team who's been here.